then I might hand over to them if they join. But welcome I think, I don't know what number report out we're on, but it goes on and on. Welcome to our report out. We've got 4 brilliant items for people to look at today. And if we just move on the slide. And I should have done this on the previous slide, but just a reminder, if you could stay on mute. But I really do hope people could use the chat, please. So, oh, Bronnie's already in there. So Bronnie's always saying uploaded. So we will share the videos of these presentations, and people are interested from outside our trust, actually, what we do. And I know the non-execs and execs enjoy listening to it. So thank you for the time you spent doing it. Bear in mind, all this work we do hopefully supports an improvement culture at UHP and beyond in our system, because we do have a big influence. So thank you. Next slide. Just a reminder of our practice. Core to our practice is respecting staff and involving them in improvement, valuing stuff in terms of what it does to patient care and how it represents value to patients, and enabling teams to drive it. And there's lots of brilliant ideas out there, and hopefully the stuff that improvement helps some of those get shared and implemented. Next slide. So just a reminder of the 5 things we try and create when we work with teams: real clear purpose, hopefully people using plan, do, study, act, and learning on each cycles, clear metrics, they know they're getting better, hopefully a team huddle that means they work together really, really well and get everybody involved. And probably our newest addition to this, but it's been in place now for 18 months, building the team and making the team stronger through team health. And just reflecting. And by the way, that's going marvelously well. So next slide, thank you. So we've got 4 presentations today. Birch is hopefully getting ready. Kelly, Carla, and Lynn might be in there floating somewhere. AAU, and I think Nat's talking to that. And then Kevin, thank you. I can see you top of the screen on mine. So then you're there. And I see you're already excited because you tweeted about your presentation already, which is fantastic. So well done. We do tweet, or comms or ourselves will tweet about the presentation as we go along, and then a really great update from neuropsychology at the end. So you're all welcome. Can I just remind people, please, if you've got questions or even comments, and please put them in the chat as we go along. We'll try and pick them up. So I'd like to hand over to Kelly and Carla for your Birch update. Thank you.
Thanks, Richard. So my name's Kelly. I am the senior sister on Birch Day Case Unit. I'm with my colleague Carla Bridle, who's the junior sister, and we're going to talk about our improvement within Birch Day Case Unit. So our purpose on Birch is to keep our patients the centre of all we do by providing safe, effective, efficient, compassionate and timely care. Therefore, our team improvement is to reduce patient waiting times from arrival in the waiting area to them starting the treatment with the nurse. We decided this improvement was required by listening to the voice of the patient verbally and via a questionnaire that we gave them. We've also taken into consideration the friends and family feedback, although predominantly our patient feedback is very positive. However, they both did highlight the length of the wait as one of their issues, which we've popped a graph just on the top right, and that part in the middle shows just where that's the patient wait time. So twice weekly, we've been having a morning improvement huddle. We use this opportunity to ask staff what areas they felt could be improved. Patient wait time and staff not leaving on time were the 2 issues that come out on top. To begin with, we collected daily data of the patient arrival time and the time the patient was seated in their treatment chair. We looked at the daily staffing numbers, the numbers of triage patients that attended the unit, and then variables that could also affect the waiting times. For example, our bloods and review patients that then require treatments. We collected this data across 3 weeks, and there's a graph at the bottom that shows that our Thursday and Friday had the significant longer waits. Thursdays had an average total of 6.12 hours, and Fridays had an average total of 15.5 hour wait. It was decided then, when we looked at the data, that we were actually unable to move these patients from the Thursday and Friday. So we then looked at what changes we could actually make on those days to try and improve that waiting time. Next slide, please.
Hi, it's Carla speaking. So yeah, although we were aware that on occasions there are waiting times that our patients experience, we were quite shocked by the data that we found. The data collected was presented in our team improvement huddle, and we then looked at, in order to address this issue, we gave the staff the opportunity to come up with individual suggestions. We did this by giving our staff time during the improvement huddle to complete a suggestion form. In total, the staff came up with 15 suggestions, of which we decided to focus on the following 3. Firstly, scheduling. We looked at the time it took to complete each treatment and how much nursing time was required to carry out the treatment. The information has been compiled into a folder in which we use in the training and education of our new ward admin team. A further change that we have made that has made an improvement already in our patient flow is utilising a phlebotomy service on level 6 and at the Future Inn. The graph, as you can see above, demonstrates the data collected across a 3-week period. On the left-hand side is the data prior to us implementing the change, and it is an average across Thursday and Friday. To the right, you can see 3 weeks of data collected since the changes have been implemented, and they show a total average improvement of 3 hours, which totals to a 13.89% improvement. Next slide, please.
So as a team, after seeing these figures, we were very excited that there was actually a noticeable improvement, and we're hopeful in the next few weeks that we will see further improvement in the waiting times. To ensure this happens, we will continue to educate and support our staff. We'll also begin to look at the variables that could potentially skew the data. For example, our staff and vacancy and sickness, our skill mix, patients that have escalated from review to requiring treatments, and then patients that attend the unit after triage and often need treatment or admission. We did look at the staffing levels on the day we collected the data, and we did have our established amount of nurses working on those days. However, it was noticed that we did receive a sizable number of triage calls, which developed into attendances on the unit and a possible admission. This process can be timely and can divert one of the nurses' attention, taking them away from the daily workload. So delays in staff leaving were largely due to waiting for an inpatient bed. So therefore, we do believe that triage is one of the variables that does have a big impact on our patient waiting time. So our plan is to continue to see a reduction in the patient waiting times with the changes that we have already made, and then focus our improvement on these variable aspects, which will probably start with triage. We want to look into this because this is the patient pathway that we would like to improve and continue, as it does prevent a lot of our haematology patients having to attend ED. So, thank you. Sorry, Richard, you're on mute.
Yeah, I'm off mute now. So you got lots of claps and hearts. I think the audience have just said what I was going to say, which is Kelly and Carla, really well done. Please pass our thanks on to the team. But there are a couple of questions I just, not to trip you up, by the way, to share learning. I guess one from, I just want to pick out from Fern. Thank you for the feedback, by the way, Fern. Was a question about when are you going to next go out to patients and ask for more feedback? So you did some at the start. When's your intention to talk to patients again?
So what my hope is, because the way we schedule, our patients are scheduled in for the length of their treatment, which can be up to 3 or 4 months. So what my hope is with the scheduling in the next sort of month, we will really see another improvement. So potentially then I will look at the results of that and then also go out to the patients to see if they see an improvement.
Fantastic. And I'm not picking up any other questions in there apart from lots of really nice comments about the approach, by the way. So really, really well done. A big thank to you both, to the team and to Lynn, who's also helped support you in there, and some great coaching and encouragement. But really well done.
Yeah, thank you.
And you do have a question from Mary, which is a patient story at PEC be a good addition to sharing of this project in time. So as a comment there from Mary, you want to look at, and so maybe a patient story, because I guess what do the 3 hours give patients back? You know, what's the difference make to them?
Yeah, that's definitely something we can look at and get their feedback from.
Brilliantly, really well done.
Thank you.
Thank you.
Sorry, someone said they need to sort triage. Okay, so he's. I think that's an offer of help. Is that from Rob? I don't know. We'll come back to that. But really well done. I'm going to. Any more comments? Please put them in. We're going to move on. So that's awesome. So thank you. And now we're across to the capable hands of Nat. You've got about 6 or 7 minutes, Nat. Thank you.
Okay, hi. So I'm Nat Davey. I'm the support manager on the acute assessment unit. We have only just started our admin huddles on the unit, which are held twice weekly. Next slide, please. So our purpose on the unit is to ensure the AAU is a smooth running unit and welcoming for our staff and patients. Firstly, we looked at uncoded episodes, exploring why we have a backlog, current processes and what improvements we can make. We also asked the team for their patient focused ideas and what improvements we may pull from this. Next slide, please. So our uncoded episodes, before COVID, we had an urgent 8 till 9 daily slot where notes would be collected and returned. This ensured notes would be coded in a timely manner. It was a very accurate system and meant that all notes were back for patients who were returning that day. During COVID, however, the coding PTL was historically sent once a month. Due to the time lag, notes would rarely be back on the unit any longer, or sorry, be on the unit any longer, causing additional work for admin staff and potential for coding to be missed. We've met with the coding team to discuss the process and how we can make improvements. Daily emails should now be sent to the admin team. There are still problems with this, which we need to look into further, which is about timeliness of emails being received, duplications of requests, timeliness of notes returned to the ward, and significant gaps in daily emails. The next steps are for myself and one of the admin team to go through the data so far captured and to further understand the peaks in the data. We've already identified some discrepancies in the data, such as duplication or patients that have been admitted. So we're going to further meet with the coding team to understand if there are any problems from their end. And we have continued with small steps in our process to ensure that we are streamlining what is required from our perspective, which will mitigate risk and increase the number of uncoded episodes. Next slide, please. So within our patient improvement focus, we stood back really and just let the team decide what they wanted to put forward to us. In summary, it was reported that our ED early patients often arrived unfed, cold, and the general patients were not always made aware that they could be with us for some time. This caused the patients and the staff distress. So we used the pick charts and were able to implement and roll out the team suggestions as soon as were practicable. Next slide, please. Rather than patients remaining hungry, thirsty or cold and waiting until the twice daily trolley round, on admission the admin team now ask ED early patients whether they require food or drink. The team then either get this for the patients straight away if they have time, or we've introduced magnets which the team put on the whiteboard to indicate whether food or drink is required. Blankets are then also sought when necessary. Next slide, please. We've also got the messaging service that's set up through System 1. So as patients were often attending the unit unaware of how long they could potentially be here, through our System 1 SMS service, we were able to send out a generic message to inform patients of what to expect. And where to go and what to bring. The message is tailored at the end of each day and then sent out to the relevant patients. There's been one hiccup as such, which was attributed to an Outlook national problem. However, we were able to amend this by using tomorrow. Instead of writing tomorrow, we were able to make it date specific. This has resulted in the patients being prepared for a longer stay and able to bring their own refreshments and entertainment, i.e. books or their iPads. Relatives are also aware that they need to return to collect the patients rather than stay and wait. Sorry, next slide, please. There are some, this is just some of the compliments and gratitudes we have received since implementing such small changes. That's the presentation complete. Thank you.
Natalie, can I just say thank you very much and thank you, team. As ever, I think you're a little bit understated in what you've done there in terms of, I think some of those small improvements, I'm sure, are really, really impactful for patients and make a big difference to what would be a worrying or a thoughtful stay on AAU. So really, really well done. Really great to see it. I mean, I've got a question, but there might be some questions in the chat. I'm just going to have a quick look. I did ask, and I know Becky might have already answered it in the chat, but the impact of the metric on own coded, how does that impact on patients or the unit? Because I realise you're struggling with maybe a response not just from you but others in the system. But how does it impact on patients?
For the uncoded episodes, I think for the hospital, it's all about getting the income and better services for them through having their coded episodes back in time for us to be able to see the patient the following day as well. If those notes aren't back, then obviously still up on coding, then we haven't got all of the information that we need for the patient that day.
Yeah, and my next question was, how's the team feeling about huddling and doing this work? What's this kind of sense in the team?
I think to begin with, certainly trepidation was in the air, if you like. They were all, oh no, we don't want to do that. And most of them were nervous about coming forward. But I think because they are a good team, they have worked with each other for so long, they're quite quick to come up with ideas and stuff. When we just put patient up on the board, gave them all of the dockets as such and left them to it to write their ideas down, and they were really good about not just writing down what they could do but how they could make it better. It was very good.
So well done. And I'm just want to pass your comment again. There's a nice comment from Mary as well, because this topic is actually part of a bigger topic in governance, a cross-cutting theme, access and waiting is quite a theme across units. We got a hand up. So Becky, jump in.
Hello, hi. I think the difference that the SMS messages are going to make to patients is huge. So it makes patients realise that they need to, that they're welcome, you know, they're expected on the unit. It actually also cuts out the number of patients who don't attend for whatever reason, and also gives them that little bit of expectation. If they've got a dog to feed, that they might be with us for some time. And as you know, Richard, there's another improvement thing going on about the length of time. So, but the food thing is brilliant. The admin staff were very much, they've picked the top things that they get asked at the reception desk by patients, and they've actually themselves, you know, worked through those issues. We're very proud about those.
So can I just say thank you, Becky, for doing that. Congratulations, everybody. And it's nice of Becky to say, as you know, Richard, but what she means is, of course, AAU will be cracking on with a whole range of improvements across the board, because you've been huddling for eons now, haven't you? So I would say super skilled team. Lovely to see work. Not holding you as a hostage of fortune in that statement, by the way, but I know you do great work. And well done on the leadership, but also well done on all the work you've done. You know, it's simple changes can make a big impact on people. And I think it's a real good testament to looking at that and resolving it. And you've got some nice compliments in there. So fantastic. Thank you. Becky, would you mind putting your hand down? Or is that another hand from somebody? It's just thank you. All right. So we're going to move on. So really, really well done, team. Amazing. And Mary's got a nice compliment in there for you as well. So really well done. So Kevin, you're on.
Hi, thank you very much. So my name's Kevin. I'm the assistant practitioner with the Parkinson's specialist team in the hospital, primarily looking or overseeing care or assisting with care for patients admitted into UHP for acute admissions, and also elective surgery as well. One of the reasons we're looking at CATA as a project really, or as a tool really for a project, was to help with trying to reduce the number of admissions through the front door of people with Parkinson's to UHP. We did have some data, some HES data recently to show that the overall cost of Parkinson's admissions for 2019 to 2020 was in the region of £6 million for 1,175 patients. So obviously one of the things we're looking at is how we can reduce either the length of stays or the actual admissions through the front door. So next slide, please. So basically, the idea was to see what way we could improve our or what assistance we could offer as a team to the front door areas of UHP, particularly for ED, for example, just purely because the majority of patients do come through via ED. We have been looking at AAU as well. But as I said, the majority are coming at ED at the moment, so that's where we've been focusing our attention at this stage. We've monitored over the course of this year how many admissions we've been getting on a weekly basis through ED and the reasons for those admissions as well. The reason we were doing this then is to look at, first of all, is there a trend on our emissions? And our trend over this last 6 months has actually been dropping. And I don't think that's through a result of any interactions we've had with ED. I think it's just more of, at the moment, because of COVID, the emission rates at the beginning of the year were quite high, infection rates were quite high, and I think a knock-on effect of people not seeking the support and assistance in the community brought them into hospital with challenging issues that turned into acute admissions. So that trend is dropping a little bit. But the reasons for admissions do remain fairly high. Falls being the first sort of or the top reason for admissions, constipation, decreased mobility, the other conditions that tend to follow there. So we're looking at what we can do then to prevent those people from coming in via ED, and what we can support them with, or what we can support ED with to try and reduce that. Next slide, please. So we originally looked at the possibility of having the Parkinson's specialist team support ED by responding maybe within sort of a time frame of a couple of hours upon admission or patient presenting to ED, to see if there was any support we could offer, any advice we could offer, and look at maybe turning this patient around and having them discharged rather than coming into hospital if it was a sort of Parkinson's specific sort of issue that we could potentially deal with in ED. This was looked at sort of we were looking at the impact this could have on our service, not only of how we could benefit ED, but also how it's going to impact our current service, our current Parkinson's service within Derriford. And one of the things we found there was, obviously, we had staff constraints due to just basically the number of staff we've got within the team, but also clinical and ward commitments as well. But also we were looking at continuity of care. We wanted to make sure that the patients coming in on an evening or a weekend get the same care and assistance that our patients get during our ED, our Parkinson's team working hours, which are Monday to Friday. So we found at this time, we feel this is probably not a viable sort of solution that we could offer. So therefore we thought, what could we then do to support ED? And that was to look at bringing in a Parkinson's assessment for patients that are admitted to ED. And so to do that, I've been to, so next slide, please. To do that, I went to ED myself, conducted a survey with members of staff there, based on, we used some very sort of basic questions about Parkinson's, asking about the staff knowledge, and this was a variety of staff, so it went from consultants to HCAs and people people of all levels in between, asking about the general knowledge of Parkinson's, where to source Parkinson's meds, for example. Unfortunately, there was only sort of 55.6% of staff didn't know where Parkinson's meds were kept in ED. And this is basically the idea of this was to look at what education resources we could put in place to support ED. So along with introducing a clinical assessment, we were looking at what resources we could give to ED to back that up so then they can access that. So based on that, we come up with a resource package which we've now put online, which is accessible on the UHP's website. So you're not reliant upon having a computer in front of you for StaffNet. You can obviously access it from any device. And that provides lots of resources for the emergency department on how to deal with patients with Parkinson's, how to source information, and information in regards to medications and where they can find medications as well. One of the things we did highlight, obviously, the area of concern was the medications itself. Parkinson's medications are time critical. We were trying to make that as a key element of this as well to our colleagues in ED. One of the things we did find there is that people with Parkinson's were not getting their meds on time because obviously the wait may be in the ambulance or in ED itself before they're then getting seen and getting medications prescribed. Issues with that is obviously not getting medications on time causes a Parkinson's patient to wear off very quickly. And that means we're looking at then a longer length of stay. Missing 2 or 3 doses of medications could increase Parkinson's patient's length of stay by a week to 2 weeks. Also missing even as low as 3 doses within a 24-hour period could have a detrimental effect on patient's health, and in worst case scenario, thankfully has not happened, could mean death as well from a condition called neuroleptic malignant syndrome. So that's obviously something we want to very much avoid. On the back of that, I've managed to sort of within this week have an alert put onto IPM, which highlights a patient is on a time critical medication. That's obviously not just for Parkinson's, so that's a generic alert which can be used for any condition that involves having a time critical med as well. So that has now gone live as of Monday. We've also got a meeting coming up with Lenny to discuss having this sort of information put on safety briefs, not just in ED but around the hospital as well. And also we had a meeting this morning with pharmacy who are going to make sure or try and put sort of an easy identifiable area down in ED to highlight where Parkinson's medications are and ensure staff down there know where to get them and how to access them. So that's been a positive thing from that. Next slide, please. Sorry, I know I kind of jumped ahead a bit earlier, but this is just the graph there showing our trends for admissions of people with Parkinson's over the last 6 months there. And as I said, we kind of had a little dip. It's kind of gone up a little bit now or over June, but I think again that's been as a result of the spike in COVID infections, but also the hot weather as well. It's not great for people with Parkinson's. So next slide, please. So as a result of the survey, what we're now looking at doing, where we are at the moment, or where I am at the moment with the project, is to look at developing the assessment tool that ED are going to use. Originally, this was going to be a paper format, but obviously with the introduction to the Nerve Centre and the feedback I've received from ED staff, the idea is to have this electronic. So when Parkinson's patient presents at ED, they will have this assessment tool flag up, hopefully on Nerve Centre. This will give them various prompts as to what to do, where to go for help, just highlight various sections of their condition, have they got the medications, if not, where to get their medications, ensure they're given on time. is the presentation in relation to constipation, for example, UTIs, something that could potentially be dealt with in ED, turned around, and hopefully the patient may not need to be admitted. If they are admitted, at least a very basic but clear Parkinson's assessment has taken place. Therefore, that will give them information to the admitting ward, for example, MAU or SAU or something like that. So it's kind of giving them an head start there from a Parkinson's point of view, and also provide us with some background information for any input that we might need to have with that patient. We've received some great information from my colleagues across the country, really, from the Waltham Centre, from King's, Oxford, and that's been a mixture of geriatricians, ED consultants, and Parkinson's consultants, all looking at what we could include in this assessment. So that's in the development stage now, and then we'll go back to ED with an education package and basically deliver that education package based on the resources available and also how to complete this assessment. We've been looking at where to go forward for this, and also potentially stop patients coming into hospital in the first place. So therefore, one other aspect of the project is to work with South West Ambulance. Had a meeting with SWAS very recently, which was very productive. SWAS have agreed that once we've got our assessment up and running, they will be keen to adopt the same assessments that their paramedics could use in the field to potentially prevent their patients from coming into Derriford in the first place. So that's something we're going to work with there. We're also going to do some education with SWAST as well. So the ED survey that I did with the staff down there, we're going to do with the paramedics outside UHP, and just basically get a bit of feedback from them on the general knowledge of Parkinson's, and based on an education package around that, which we can deliver outside of Derriford to ambulance crews, sort of whilst they're on their breaks, or whilst they've just handed over a patient and they've got a bit of time to spare. Because we found just by the feedback from SWAST that we're going to have a better reaction from having like a pop-up education session rather than we would if SWAST were to put together an e-learning package, for example, that they'd be very much relying on goodwill of staff to complete during during their own time, really. So that's sort of going forward really there with that. I was also invited onto the I'm going to have to read up on read the name of this again because I always forget, the Integrated Urgent and Emergency Care Improvement Wall, which I joined a couple of weeks ago, and I think I've got a session again today. So that's going to give me sort of an avenue into other areas within the community, such as the GPs, 111 service, where we're looking at also hoping to provide some education sessions with those groups, and hopefully again making them sort of broaden their knowledge and awareness of Parkinson's, what tends to bring patients with Parkinson's into hospital, and how we can avoid that from a community point of view as well.
Wow, Kevin, awesome.
Thank you very much.
I think that deserves a round of applause, by the way. So fantastic. I just want to go back. Sorry, I'm just going to go back. I'll come back to this. So really, really well done. There's been lots of comments which have been really, really positive in there. And you've obviously done a few things which are phenomenally important. I just want to ask you one question, which isn't about the Parkinson's process, but doing this via storyboard and having a coach, so the discipline of that. How have you found it? I mean, has it helped you? Has it felt awkward? What's been your thought on it?
It's been a massive help, really. Having been involved in other projects in the past and sort of a previous life, as it were, you tend to kind of throw yourself in, and you sort of start one aspect of it, then start another aspect, and then go back to this and go back to that. But I think using the storyboard approach and having the coaching sessions expertly provided by Ryan, it's given me a way of looking or dealing with one particular issue and one particular area first, seeing where I can go from there, and then if I hit a problem, how to deal with that, rather than think, right, we've hit something there, let's move on to something else. It's kind of dealing with that, tackling with that issue, tackling that sort of barrier, as it were, overcoming that before then moving on to the next approach of the project, really.
Well done. And can we just move on to the next slide, please, Bryony? So I just want to say a big compliment, firstly, to you, Kevin, because this is your certification for CATA. But more importantly, you've done an amazing thing on the Parkinson pathway. So hugely well done. I'm sure I appreciate it. But also, it seems you've added to our SALA CPMA and other facilities in the hospital by creating this timely drug alert as well. So really well done.
Thank you.
I also want to say well done, Ryan, for coaching you and the diligence on CATA. And I forgot to do this for Vicky in the last presentation. I mentioned it up so far. So Lynn for Birch, but Vicky for ambulatory. Again, awesome that you've got coaches helping you. So really well done. Great work. There's obviously. Oh, so I've answered Kev's question. Oh, great. Thank you. All right. So well done, Kevin. We're going to move on. Thank you. Right. So Chanel, I think you're up.
Hello. Yes, I'm not too sure if I want to follow Kevin after that amazing presentation. Hello, everyone. I'm Chanel. I'm the support manager in neurology. And today I just want to go through a few of the improvements that we're doing in the neuropsychology huddle. You can go on to the next slide, please. So we've been doing the neuropsychology huddle for a short while now, probably just short of 2 months. We have these huddles every Thursday morning. We do them face to face, and you can see a nice picture of us down the bottom right hand corner. We are smiling. I know you can't see with the masks on, but we do them face to face, and I also take the laptop down as well, just to allow those that are working from home to participate as well. I think it's just nice to be able to have these huddles face to face, obviously with everything that's been happening with COVID for the last couple of years. But it's a really engaged team. It's a small team, but they're all really engaged and all keen to make improvements. So that's really, really good, obviously, having the huddles. With regards to sort of the setup, it's a sort of standard setup that you've got. So obviously we're looking at the improvements. We've got our metrics and data. We're going through our test to change. We've got the what went well, the even better ifs. And then we've got the team health. So the team health hasn't started yet, but that's going to be starting from next week. And with our agenda, we thought we'd get a little bit creative with it. So obviously we've spelt out neuro, and we've just got neuropsychology service, efficiency, utility to clinical care, research and evidence-based intervention, and on a timely basis. And you can see there in the bottom right-hand corner, there's a little setup of our huddle board that we've got in the neuropsychology corridor. So if anyone's walking past, feel free to have a little look. Next slide, please. So one of the first areas of improvement that we're working on is patient correspondence. So reducing turnaround time for patient correspondence, obviously once it goes on to Big Hand and once the patient receives the letter. So we want this, as patients can sometimes wait longer than they should be to receive their letters. And by improving the turnaround time, we lessen the patient's anxiety and also improves that communication with the GPs. So one of the first things that we are working on is initially reducing the typing backlog. So that's sort of the first step in the process. So when we first started this, I think we had 64 letters in our typing backlog on Big Hand, and this week it is now at 7. So that's such a good drop, considering the short amount of time that we've been working on this. So what we've done to achieve this is the team have got together. The secretary has had dedicated typing time to work on clearing these letters. We've also had a member of staff helping with some shifts on NHSP, and we also use the software Dragon Dictate in the department. A couple of clinicians use that, so I'm not too sure if everyone's familiar with this, but for those that aren't, it's essentially it's a software that will automatically transcribe. So the clinicians will dictate and then that will transcribe. So it essentially cuts out that middle section and time of the secretary having to type it because it's already there, which also allows the secretary to get on with other things. But I do just want to say, obviously, with this, with the typing coming down so much, I think we also need to recognise we only have one secretary in this department, so for it to come down that much in that short time frame is really, really good. So that's really positive, and now it's just a case of keeping it low. And obviously after we've done the type in, the next step is then to look at the sign in and how we can reduce that sign in gap then to get a quicker turnaround with that. Next slide, please. So the next slide that we're working on is waiting times. So we want to reduce our waiting times for both new and follow-up patients. Since the huddle has started, we've reviewed the follow-up and new PTL to identify any DQ errors, making sure all the patients as suitable to be booked are being booked. A lot of our long waiting patients are for a specific clinic. So you can see in the graph there that our longest wait is 130 weeks, which is really, really long. We've got 20 patients on the PTL, which are a set cohort of patients really that they can't be booked into general clinics. And we've spoken with the team and we have a plan in place to get these cleared in the next couple of months. So we've met with the clinicians, we've changed clinic profiles, changed to make sure obviously that the correct amount of new patients are being booked. And with these cohort of patients, we're going to be changing some clinics around to get them all seen. So I'd like to see possibly in a few weeks' time, this little graph here will come right down and obviously going in the right direction. Also our median wait for new appointments, that's also coming down as well. I appreciate obviously things like follow up in new waiting list times. It's not something that can sort of change overnight. It is a process. So we'll continue to do this and oversee the PTLs and the waiting lists and change our capacity where needed, and also continuing reviewing the PTLs with the admin team. Next slide, please. Oh, also, sorry, back on that slide. We have also explored more room capacity in main outpatients, just to sort of see if we can do extra clinics and things like that to try and get waiting lists down as well. Next slide. So the final slide then, so the next area of focus that we've been working on is our inpatient management. So at the moment, we've established that sometimes the patients on the wards can sometimes take quite a while to be reviewed by the neuropsychologist, sometimes up to about 6 to 7 days before the patients are seen. And there could be numerous factors because of this. It could be staffing issues, there could be some of the psychologists being on annual leave or sickness, and it also just depend on how many referrals that the team are getting each week. So we've got together, and what we're now doing is moving from the current red top process. So at the moment, the team still receive paper red top referrals. And obviously the issue with paper referrals is they can easily get lost, and also requires a member of staff to physically hand deliver the referral, which essentially takes time out of their day. And there's also no visibility of the progress of the referral. So we're soon going to be moving to electronic referrals on Sierra. And Ryan and the software development team have been amazing with helping this happen and make this move forward. So what the team have done so far is we've got together and reviewed the content that needs to go on to the referral, and the one of the members of staff from the software development team last week, she came to one of our huddles and actually presented this so we could see what the final was, what the draft referral would look like. So now we're just need to develop our custom list, and then the next step would then be to trial this and then essentially make this go live. So I think that will be a big improvement for the team, going electronic instead of paper. So hopefully it won't be too long until that's there, and then obviously when we're ready to go live, we'll communicate it through obviously various departments, put messages out on the daily email and things like that. So yeah, so that's the improvements that we're working on at the moment. So obviously it's still a long way to go with some of them, but I think obviously considering we've only been doing the huddle just short of 2 months, it's all going in the right direction.
So can I just say a huge thank you, and to Ryan again for your coaching of the team. And so thanks back to all your team, by the way, because I know this is a big team effort. So hugely well done. Before I take any questions, I just want to do a bit of reflection on some of the stuff I've listened to today, because it's been, we didn't intend for all these 4 things to align together. They just happened to be the ones. So I think Mary's made a comment about there's been so much today about waiting and queuing and quality governance. So I hope that helped you, Mary, by the way. The things that I've just resonated today, by the way, were listening to staff and listening to patients, and how not just to take the odd word, but to do that properly and get value out of it and information and data that you can use. Really great. I've seen some brilliant use of suggestion sheets in some of the presentations today, and how powerful that is to give people time to think, even though it takes only a minute or 2, but actually getting people to do that. Some brilliant huddles going on there. And I just commend the last one for the clarity of your huddle board, by the way, was truly impressive. Using a CATA storyboard or an 8-step as a guide to your method to make sure you don't get stung by one barrier and you overcome it. So really well done. And looking across the whole stream, so looking at how referrals come, looking at wards, giving medicines at the right time, working down the stream as far as SWOS, picking the broader issue. I mean, all of those things from the 4 presentations I've seen today have all helped access weights and time for patients. And isn't that great for patient experience? Because I guess lost time and just sitting there is just truly sapping for people, but also really important. So I just want to say a huge well done to everyone's presented today, because it's awesome. So give yourself a round of applause. It's fantastic. So I'd love to see that, Martine, so proud. So completely agree with you. You've all done brilliantly. So we'll move on to the next slide, please, Bryony. And sometimes I've done my reflection, so I did apologise that I did my reflections bit. Make sure if you're on leave, by all means, enjoy your leave. On August 25th, we think we've got 5 more, at least, it might be 6 more presentations coming. A couple of practice coaches, maybe an update on Mayflower. AAU, hopefully, Becky, you're going to come and talk amazing things about what you're doing on flow and AAU, we hope again. And we've got some stuff on dispensing flow as well. So lots coming, and there might be a few more. So please keep up the great work. Please let people know how this runs, and I hope you enjoy the rest of your day. Thank you very much.
Thank you.